Now it is my pleasure to introduce Professor Jennifer Chandler, who's going to be talking to us today about organ donation and physician-assisted dying. Professor Chandler joined the University of Ottawa Faculty of Law in 2002 after practicing law in Canada with a national law firm and serving as a law clerk to the Honorable Mr. Justice John Sapinka of the Supreme Court of Canada. She is an associate professor at the Faculty of Law, where she teaches mental health law and neuroethics, as well as medical legal issues and tort law. She holds a reading group for students interested in ethical legal questions raised by emerging research in cognitive neuroscience and behavioral genetics, as well as issues in mental health law. She also has taught a graduate level course called Technoprudence, which addresses philosophy of law and technology. Professor Chandler researches and writes about the legal and ethical aspects of advances in biomedical science and technology, with particular interest in neuroethics, organ donation, and regenerative medicine. Recently, she has written on the legal implications of advances in neurotherapies and neuroimaging technologies, regulatory policy related to medical practices such as organ donation and transplantation, as well as the ethics of law and scientific inquiry. So it is my pleasure to welcome Professor Chandler here today. Please join me in welcoming her to the stage.
Thanks so much, Megan, and thanks to you all for being here on this very Ottawa-like weather, actually. We haven't caught up to you yet, but it's coming, I know. So I'm very pleased to be here at the invitation of my excellent colleagues in the Canadian National Transplant Research Program, Tim Caulfield at the back and Megan. Thank you to you all. So the topic that I'm going to address today is the ethics and legal issues that are emerging with the potential of there being organ donation after physician-assisted death here in Canada, which obviously has not been an issue until the Carter decision this winter, and wondering a little bit about what the existing laws might say about this, if anything, and posing the questions of what should they say perhaps about this, again, if anything. And what might be some of the ethical or other legal issues that might emerge, for example, if, I'm hypothesizing now, doctors decide to actually preclude people who access physician-assisted dying from going on to donate. And that last part of my talk is more speculative. I'm working with my graduate student, Sherry Yazdani, on this. But I wanted to lay out for you some of our preliminary thinking about this and what might be the issues to look at. So I propose to talk for about 30 minutes or so, and then invite you to ask questions or if you have comments or thoughts on the topic, that would be wonderful. So let's start at the start, which is last February, we hear from the Supreme Court in the Carter versus Canada decision that the criminal prohibition in certain circumstances on physician-assisted dying has been struck down. There is a right, again, in certain circumstances, to access physician-assisted dying and not to be impeded by the legislatures in accessing it. So what did this case say, at least for the purposes of our discussion here? We know that the criminal code prohibitions that bar physician-assisted dying are now void for people who are competent, adult, who consent to the termination of life, and have a grievous and irremediable medical condition that causes enduring physical or psychological suffering that's intolerable to the person concerned. So we can notice a few things here that distinguish this situation from, for example, the American euthanasia statutes. There's not a requirement here that the condition be about to generate death in the next sort of 6 months, for example. So there's no requirement that death be imminent. The essential limitation on this is put by the requirement that there be a grievous and irremediable medical condition, judged again from the perspective of the person experiencing it. So the declaration striking down these provisions was suspended, as you know, for 12 months. The Supreme Court often does this when there's a major change being introduced into the law to allow the legislatures and practitioners time to adjust and figure out what they're going to do. So 12 months is going to be up this coming February. And we don't yet quite know what the response of the provinces and or the federal government will be to this, if any. Some wonder if maybe there will be any response. And if there is none, we may be in that kind of situation we were in after the abortion laws were struck down, and we just continued on without any laws. There are media reports that the federal government may ask for an extension of this time period to have enough time to come up with well-considered policies. Another important piece to note from this case is that the decision does not compel any physician to provide assistance in dying. So, all right, fair enough so far, but what about the kinds of medical practices that take place at or around the time of death? And here I'm thinking of organ donation. What is the implication for the practice of organ donation of this decision in Carter and the potential move toward allowing physician-assisted dying in Canada? And this, the possibility of there being an impact was not lost on commentators at the time. There were a lot of coverage in the press saying, whoa, wait a minute, doctors now worrying about how organ donations will be affected. I have things on the right-hand side, organs of those killed by euthanasia being used, sort of showing the potential public relations kind of ramifications. I think that this is bound to be a controversial kind of nexus of bringing these two together. We'll talk more about why that might be in a moment. Better Off Dead, Belgium and Netherlands are currently engaging in the practice of, well, they've been for many years before us, have had systems of physician-assisted dying and have had to confront this issue of whether it's possible to have an organ donation after that process, and indeed are going ahead with it, although it doesn't tend to happen very often. And again, you see in the bottom left, chilling concerns of killing people to harvest organs. Now, again, I put this up there not to suggest this is what will happen, but to show the kind of public relations reactions to these two things coming together. So, how would this even happen? So let me just run through for you very quickly sort of what would the process be if someone were to have physician-assisted dying and organ donation. And for many years, until about 2006, organ donation in Canada, I'm talking about posthumous organ donation, not live organ donation, one kidney by a living donor. I'm talking about removal of organs after someone's dead here. And that was mostly done in the context of brain death, or death determined according to neurological criteria, where a patient would be ventilated. This would be maintaining circulation and oxygenation of the organs, and organs could just be removed because the patient was dead on brain death criteria. Excuse me. Now, this is a very narrow set of potential donors, and in 2006 there was a move to expand to include what are called donors after cardiac or cardiorespiratory or cardiocirculatory death. So this would be slightly different, well, actually very different, and would work along these ways. There would be a decision taken to withdraw life-sustaining therapies for a brain-injured patient. Usually brain injured, but not necessarily, but somebody who is being ventilated. This could also include people with ALS who have paralysis, neurodegenerative conditions that are also being ventilated. But you have a decision that's taken to withdraw the ventilation. After that decision is taken, there will be another discussion about whether the person wants to donate their organs or not after their death. If there is consent and agreement to both of those, then they will move forward with the process, which will start with the withdrawal of the ventilation. Heart attack and circulatory arrest would occur after that. And then there's various issues which we don't need to talk about now about the amount of time that might take and whether, if it takes too long, it would foreclose donation. But let's assume that the patient proceeds to a heart attack and circulatory arrest quickly. Then there's a waiting period of a number of minutes, which varies from place to place, to verify that in fact death has occurred, that there's no possibility of the heart activity resuming, and to also verify that a certain amount of time has elapsed will ensure that brain death has also occurred. And then after that, removal of organs and tissues takes place. And there's a tension between the amount of time that's left in this waiting period, because the longer you wait without circulation, the more anoxic damage is done to the organs. So it's kept short as possible, but not too short, so as to produce concern about has the death really occurred and resuscitation is not going to occur. And there's a picture here of Sarah Beth Terrien, who was the first Canadian DCD donor back in 2006 in Ottawa. Now, so that's the process I've set out for DCD. We're not talking, you will have noticed there was no discussion of physician-assisted dying here. So what would happen if there were physician-assisted dying? Well, essentially we're just subbing out the withdrawal of life-sustaining therapies and adding in the decision to administer physician-assisted dying. I'm calling PAD here to ease your eyes on the slides, which would be, for example, the administration of an overdose of barbiturates. But otherwise, the process would be essentially the same. The person would pass away due to the lethal drugs, heart attack, circulatory arrest, waiting period, and so on. So this is sort of, in terms of process, what we would be looking at, I imagine. So I mentioned earlier that this is actually happening in some places, often driven very much by patients very eager to donate. And so I put up for you some citations to case reports, again, small numbers, but in Belgium, the first two are in Belgium. The following two, I believe, are, well, Van Dijk is in Netherlands. I forget where Ramdonk is. But these are 4 relatively recent publications talking about the protocol that they follow. What are the sort of safeguards put in place to make sure that the teams are separate, that there's no concern about conflict of interest and blurring of roles. Obviously, because we have a lot of things going on here. We have the care team, we have sort of people being asked to administer sort of the physician-assisted dying and organ donation and transplant teams all in the works here. The Netherlands is actually working on guidelines. I'm not quite sure if they finished them yet or not. I was unable to find out. My Dutch is not very good, so, well, it is non-existent, actually, to be honest. Who are we kidding, right? Yeah. I don't know quite where they are on those guidelines, but it's an effort to kind of sort of formalize the process. Okay, so here I'm going to now move into, I've tried to organize for you the various possibilities here. So the possibilities I'm going to put forward are not necessarily possibilities I'm endorsing. I'm just for sake of completion, I want to set out everything, every possible moment at which this could possibly happen. So let's look at the little graph. So I've set this up. It's meant to represent sort of a chronological line and indicate the points at which the organ removal could take place. That sort of little blip there is meant to indicate death. In the middle. So item 1 would be living donation by a person who is contemplating physician-assisted dying. So that's one possibility in which donation could occur in the context of PAD. There could be a decision taken to proceed with a living donation before going on to PAD. If we go toward the end, we've got donation, posthumous donation after a person is dead. And this is the DCD sort of protocol that I explained. But the third option is sometimes called organ donation euthanasia, or bringing about the death of the person by removal of organs. So it's putting the two together as closely as you could imagine it happening. And this has been suggested in the literature as well, on the theory that organs are damaged by anoxia, and if it's acceptable to kill someone, does it really matter whether it's done by application of a lethal injection or any other means? So we'll return to that in a moment. Typically when I get to this point, I see expressions of shock and horror. And indeed, that's how one would react to that, right? At a sort of a gut level, it goes right against our sort of adherence to the dead donor rule. But think as we go along with that, what does the dead donor rule mean in a regime where physician-assisted dying is permitted? Is there a reason philosophically and practically to keep them separate? I think there is, and I'll explain why in a moment. Okay, so those are our 3 possibilities where donation could co-occur with physician-assisted dying. So what is our first option? So living donation before physician-assisted dying. Well, if we look at the laws across Canada, living donation is permitted for competent adults, generally. There's age restrictions on this. And it's contemplated. There's people doing living donations of a kidney or a part of a liver not infrequently in Canada already. And so we've worked our way through the ethics and law of that and are comfortable with that now. So could a patient who's contemplating PAD also do this? And the second question, and my answer to that is I can't see anything in the laws right now that would preclude it. But where things get a little bit more complex and interesting is a suggestion that in these patients you could have an expanded living donation, because living donation is presently restricted to non-essential organs and tissues, because you cannot bring about the death of your living donor, so you can only take one kidney, a part of a liver, something that will not actually bring about the death of that donor. But it has been suggested that if we're contemplating going on to PAD, well, we could take more things from the person, because essentially they would die from the physician-assisted dying before the effects of the loss of those additional organs and tissues would bring about their death. So it would not actually go against the dead donor rule, given that they will necessarily die of PAD before the effects of the loss of the liver, for example. Now, one of the issues with this, however, is that if we want to maintain the possibility for someone to change their mind right up to the moment of the administration of PAD, if you've already donated essential organs and tissues, that's going to foreclose changing your mind. So that is a sort of a serious strike against an expanded living donation. But if we end up in a system where donation after PAD is prohibited, doctors are unwilling to do it, this might remain on the table for people in this position who do want to donate. So let's move now to item 3. That was supposed to say, oh yeah, well anyway, I've got my numbers mixed up. But the sort of standard approach of posthumous donation sort of through a DCD kind of trajectory. And again, looking at the law, I don't see anything I'm sorry, I know the Ontario law anyway. I'm not sure that I've systematically looked at all of them, including Alberta's. But if I look at our law in Ontario, in principle, it would be permissible to have donation for somebody whose death was brought about via lethal injection in the context of PAD. And if we were to maintain the safeguards that are presently in place, the separation of medical teams responsible for care, for administration of PAD, and the organ procurement side, that would be one way to continue to address concern about conflict of interest and blurring of roles, professional roles. Again, in some ways, donation in this context you might think is even more gold standard than in the usual DCD context, because you have a competent adult who has to have been adjudged very competent already because they are acceptable for PAD, who's also in contemplation of their imminent death, thinking about and donation and can ask all requisite questions. That's a lot more informed consent than we usually accept for organ donation, where we just tick a box on a driver's license or a health card and no one actually really has the faintest clue what it's all about or whether it will even happen. So one could argue that this and other similar cases of competent adults about to die, people with neurodegenerative conditions or locked-in state, ALS, who have preserved cognitive functions and also want to donate after the withdrawal of ventilation. These are sort of the very good cases of informed consent. Now, there are concerns with this, of course, as well, and they're parallel to the one I raised earlier about whether if there's advanced matching and planning done, and all sorts of things are put in place for there to be swift DCD donation after the assisted dying takes place, will a person feel pressured to continue up to the last minute? Will they feel that they, I guess the point I'm trying to make is, will it be still possible realistically for them to change their mind about the donation? Another important problem with this is that many people, at least if we look at the Netherlands and Belgian experience, want to die at home, not in the hospital, and have sort of voluntary euthanasia in the home. And if one wants to go ahead to organ donation, that won't be possible. A person will have to be right next to the operating room to proceed swiftly with the donation after the cardiorespiratory death. Okay. So here's our third option, organ donation euthanasia. And I hadn't quite thought of this myself, but on doing the literature review, I find that other people have thought of it and are saying, well, what would prevent us, since PAD is now legal, It does not clear that any method of bringing about death ought to be prioritized over another. What precludes bringing about death, obviously under full anesthesia, of removal of vital organs? And does it really matter? And you could ask, does it really matter how the death is brought about, is the point I'm making. And so one could think about this at the legal level, the ethical level, and at the level of public relations, which is also very important as well to maintain public support and comfort with the organ donation system and, frankly, with the physician-assisted dying system. So I guess what I would say with this, the reason why I think this should, I'm trying to come up with a principled reason that goes beyond ick, you know, I think I'm rather something that is more than a kind of an emotional reaction to this. And thinking about it, I think one of the concerns that we have in the area of putting organ donation and physician-assisted dying together is that in the normal course of organ donation, or I should say in the normal course of physician-assisted dying, we don't contemplate that there's others directly benefiting from our death. Now, some of the concern around physician-assisted dying is that you're going to have vulnerable dependent people who will be pressured into accepting or seeking out PAD in order not to be a financial burden, in order not to be a burden on caregivers, in order to allow sort of over-energetic inheritors to inherit more quickly. So certainly there is a possibility of someone benefiting from someone's physician-assisted dying, but it's not as much and as obvious as in the case of organ donation, where you have people dying who will be saved if you donate. So the point I'm trying to make is that bringing these two together raises very starkly, and more so than in the other physician-assisted dying case, the problem of potential conflict of interest. And it makes the bringing together of these two systems and processes more awkward when they're made into one process. So we might like to think, in the context of physician-assisted dying followed afterward by a donation, that the main act, the most important thing that's happening is the physician-assisted dying. And that if organ donation happens, it's sort of a derivative thing that happens, but that's not our main objective, right? Where we put them together, that becomes uncomfortably difficult to tell what the main objective is. Does it look as if the donation was the main objective all along and we're bringing about the physician-assisted dying in order to facilitate that? Now, I don't think there's anything logical about what I just said, but I think that at the emotional level, this might be the way we interpret it. I think it really makes, you could quite easily be aiming at the organ donation and do it through posthumous DCD. So that's why what I've said I don't think has any logic, but I think at the emotional level we do react that way. So where I end up thinking is, it may have been obvious to you all along, that I don't think we can sort of be comfortable with this. Even though it does seem a little bit weird that if we're willing to accept the killing of a person, we get squeamish about one particular method versus another, and when one of those others might actually enable the wish of the dying person to donate in the most effective way possible with no or minimize damage to the organs. So I'll be very interested to hear what you all think of that. That's me attempting to come up with some sort of argument about why it doesn't make sense, and I think it does operate at the level of public trust and comfort with the system. Okay, so I want to step now to a couple of other open questions that remain after Carter. So there's a number of things that we don't know, that we need to know, which will affect this organ donation as well and intersect with organ donation potentially. So we don't know what grievous and irremediable means. One open question is, does this include psychiatric conditions? In the Netherlands, actually, there's it's not uncommon that psychiatric suffering is the grounds for successfully obtaining PAD. And there has been some discussion in Canada. Udo Schucklink at Queen's has written on this subject, arguing that there is no principled reason why people with grievous and irremediable psychiatric suffering ought to be prohibited from accessing PAD. And I think, indeed, if there were an attempt to restrict access, that would run into discrimination claims based on the suggestion that the physical and the mental are not equally valid forms of suffering. I think where it gets a little more tricky is on the question of irremediable, when you're dealing with a psychiatric condition that can fluctuate in terms of severity of the symptoms, and where things can change, even if someone has had a long course of a very difficult time. So another issue is restriction to adults. And this raises a question of what we're going to do about mature minors. Because if we define adults as 18, we already have a whole informed consent law which accepts that mature minors can have access to some of these decisions. So I think that's another sort of pressure point that will have to be sorted out. And then when we look at the sort of limits for organ donation as well, live organ donation at any rate, in Ontario I think it's 16. A third issue that we need to sort out is, what about advance directives? Is one able to state in advance of an anticipated grievous and irremediable suffering that if I get into this state, which I presently, at time 1, am defining for my future self as grievous and irremediable suffering, intolerable to me, does that count? Can one go ahead and do that? And if so, can one sort of join onto that, graft onto that a willingness to donate as well? So a second question from the legal perspective, just check the time here, yep, is what to do about this. Is it wise to actually do anything legislatively about organ donation and physician-assisted dying? Should we just sort of ignore that from the legislative perspective and basically have some medical teams have to deal with it when it comes up, which it will come up at some point, and have to decide what to do? Is that a better way of handling it, or should we anticipate this possibility and sort of set out some sort of policy or protocol for it? I know, talking to people in the field, there's a great reluctance to go anywhere near this, I think for good reasons. One is that it is, there's a lot of sensitivity already about physician-assisted dying. It's very contentious, it's novel, no one quite knows exactly how this is going to work out. And maybe just trying to wade in there by adding on another layer of sort of controversy is not going to be helpful at this point. But I do, I accept that. I think that makes a lot of sense. In a way, I'm in a good spot as an academic in my little ivory tower. I can write about anything I want without sort of causing too much damage, because nobody reads our stuff, or rarely does. But then at least some of the thinking will be out there, and when it does actually happen, and clinicians are trying to, what do we do now? At least someone will have worked through some of the details. Maybe that's an appropriate way to handle an anticipated problem ahead of time. But I do think that it's a bit unkind, knowing that a problem is going to come down the lines, not to put something in place to help the public understand and the clinicians understand whether this is okay, if not, why not, if so, under what circumstances. So I thought, and now I'm moving into the section of my talk where I have to admit Sherry and I are still working on this, but I want to flag it for you because I think it's really interesting, and it raises an issue that cuts more broadly than just physician-assisted dying. And essentially what I'm doing here is I hypothesize, I'm sort of making up a potential rule that the doctors, the transplant programs are going to say, we're not accepting these cases. There will be someone who wants physician-assisted dying, and they'll go that far, but that person will then say, and I want to donate. And the transplant teams, they're going to say, I don't want the organs. And I suggest this because I know of a number of cases, recent cases in Canada, where a patient with Lou Gehrig's disease, or ALS, wanted to donate. And the intensive care side and critical care said, fine, we'll set it up. The organ donation organizations, fine, set it up. But then it was the transplant side that said, no, we're uncomfortable with this. And you say to yourself, why would that be exactly? We accept withdrawal of care from somebody with ALS. In fact, it's their right to have care, to refuse care. But it got uncomfortably close to that line between the killing and letting die that is at the heart of this issue of withdrawal of life-sustaining treatments. So if it's causing teams difficulty in the ALS context, it's going to cause a heck of a lot more difficulty for them in the PAD context. And so let's just imagine that the doctors are going to say, no, we will not go along with this. So you have set up a dispute now between someone who is accessing PAD, who really wants to donate, and is trying to argue that they should be allowed to donate, and the medical team saying, no, we won't accept it. So what would happen legally in that circumstance? And so I want to think a little bit about what it would mean to say that there's a right to be considered for donation. Now, I don't say there's a right to donate, because there may be many reasons why donation may be impossible. And also, there's something weird about saying, I have a right to give you something and you must take it, right? There's something very weird about that that doesn't sort of sit with our sense of an altruistic, voluntary gift. Is it a gift if I'm forced to take what you want to give me? This starts to seem a little bit odd, right? But let me sort of outline for you a potential argument that could be constructed around this idea of refusing someone who's dying, who wants to donate, who wants to have a sense of giving back to or participating in the community, to saving lives on their way out, is deriving some sort of psychological comfort from the possibility of doing that. So I've set up this funny idea for you, and what I'm doing in this slide is suggesting that this funny idea of there being a right to donate is not so funny after all. All of these cases involve situations in which someone has wanted to donate some form of bodily tissue and has been refused for a variety of reasons and has brought a human rights discrimination complaint against Canadian Blood Services, against a variety of others who might have refused the donation. So the idea that there might be a rights claim to donate, to at least be considered to donate, and to demand a justification for not being allowed to participate in the social institution of donation transplantation, has lots of precedents. Well, not lots, but a handful, let's say. So the first three cases deal with disputes over the rule precluding men who have sex with men from donating blood. Freeman, Zoldi, and Neudorf. The next one, Soulière, is an interesting case. It's an ongoing case that I've just learned about, going to the federal court, and again against Canadian Blood Services, for refusing a blood donation from a young woman with a cognitive disability. And I'm told that, in essence, the issue seems to have been that the screening process, filling in the forms to identify risk factors or whatever, was not presented to her in a form that she could respond to. And the argument from the claimant here is, well, you had a duty to accommodate my cognitive disability, ask me those questions in a way that I could respond to, and therefore I should be allowed to participate in, again, this social institution of donation. And that in keeping me outside of it, you've deprecated me as an individual. You're not letting me be part of the community in a way that's meaningful to me. Similar argument being made in the MSM cases, but they're on the grounds of sexual orientation. Woodwork was another case where it was a woman who wanted to be on the one-match stem cell bone marrow registry and was told, no, you can't join in because you have physical disabilities that we think will preclude safely removing bone marrow from you, so you're not on the list. So in that case, it was a physical disability. So I also invite you to go down the line with me with a truly bizarre thought experiment, but again to try to cement the idea that harm can be done to people by refusing their donation. Think of a strange and abhorrent kind of racist culture that says we don't accept any donations from people of race X because we just don't like you and you're not part of our circle of people who donate and receive these tissues. So I think one can feel with that kind of example that there's something clearly wrong there. And so it makes a little bit more make a little more sense, this idea that one can be harmed, wronged, discriminated against when your apparently voluntary altruistic gift is being refused. It's more than just a refusal of a gift, it's a refusal of acceptance into the community, of solidarity, and of exchange of these tissues. Okay, so I've tried to convince you that there may actually be something to this idea that there's a right to be considered and not foreclosed off the bat due to arbitrary kind of considerations. So what kind of harm is done to someone? I'm not going to go through, the human rights legal reasoning is very complicated, and it's entirely different whether it's the government that's setting a rule to foreclose, to discriminate, or versus its private parties, such as doctors, for example. And there's a lot of confusion about which legal regime you'll go to, and the particular legal tests and considerations vary as well. I'm not going to that would take us probably 4 months to go through all that. So I'm going at the very top level, just extracting some of the sort of kinds of considerations under all of these regimes. So one of the things that we have to look at in deciding whether there's impermissible discrimination is there has to be a disadvantage that is being inflicted on someone. It has to burden or harm them in some way. in terms of not having access to something everyone else has. And so I go to this 2C article dealing with ALS again, in which a woman wrote right before the removal of ventilation that she died, and then went ahead to donate to 2 kidneys and some liver to 3 people. And she wrote, and this was published in the newspaper afterward, "I'm so glad that in spite of my disease," she was a 40-year-old nurse who had worked in the area, so for her it was very significant to be able to make this donation. "I'm so glad that in spite of my disease, there's still something I can do to help others in a significant way. ALS is preventing me from accomplishing what I wanted to do in my life, but hopefully my donation will give others a chance to live out their dreams." So you can see the value psychologically to someone whose life is coming to an end, who feels she hasn't been able to do what she wanted to do. And it is not just having a legacy, but enabling a whole bunch of others to go on and have their lives. So I think with quotes like this, you can sort of see that there is a psychological value. It's not just solely an altruistic donation. There is a bit of an exchange element, that when someone donates, they get a psychological comfort or benefit as well, a sense of legacy and participation. So what's being withheld here is not so much the ability to give away a gift voluntarily, but the ability to draw the comfort from having participated and have found some meaning in the end of one's life. So that's my argument there. Now, another technical problem is that when we talk about discrimination protection, especially when we're talking about private parties who are discriminating against us, the laws require that discrimination occur in certain spheres. So you can discriminate as much as you want impermissibly in who you invite to your dinner party, but you can't for who you're going to hire, who you're going to rent an apartment to, who you're willing to sell to in your business, services and goods, things like that. So there's certain impermissible spheres of discrimination. And the one here would be a service. And in what way is the option to donate a service? And that's another peculiar hurdle that one would have to climb in order to establish a claim in this context. And here I look to ODO, organ donation organization, and medical websites that, and policies that almost all of them say something along the following lines. The opportunity for donation is everybody's right. Every family's right in Manitoba, in Saskatoon. All patients who meet the medical criteria have a right to choose it as an appropriate part of end-of-life care. So now, just between you and me, this right language is not, this is not lawyers writing this stuff. This is policymakers who are trying to impress upon doctors that even if they don't have time or they don't feel like pursuing potential donations, they are being encouraged to think that they must do so. And it's to overcome physician reluctance, perhaps, about the awkwardness of approaching grieving families and everything. It's an attempt to reframe it as a benefit or right of the family to have this choice. But even if we recognize that's what this is rhetorically doing, it is still telling, I think, that it's being framed in this way. If it is indeed a right, well, okay, let's call it a right. What else follows from that position? And it suggests to me that you could start regarding this part of appropriate end-of-life care as something that ought also to be made available to people going through PAD. So our next problem, and don't worry, I'm almost done advancing this argument, is you have to also show, and this is where I think the whole argument starts to get very difficult conceptually and legally, is even if you're being, someone is drawing a distinction and it's causing harm, and it's in a particular protected area like services, you have to show that the discrimination was on the basis of a particular ground. It had to be your race, sex, age, sexual orientation, disability, whatever is listed in the statute. And so here we have an awkward problem. Is a rule saying we are not accepting organs after physician-assisted dying, in what way is that attached to the existence of a disability? And that's the tricky thing we have to suggest or explain. And so someone could say to me, well, this has got nothing to do with disability. I mean, people who have any kind of disabilities don't have to die by physician-assisted dying. It's not a necessary sort of attribute of that disability. Therefore, there's no way that our refusal to accept them for donation is tied to their disability. No discrimination on the ground of disability. Now, on the other hand, I could say, yeah, but. I could say, well, in fact, the only people who will seek PAD are those who have some of the most serious disabilities. And in effect, your refusal to accept them forces a choice on them. that they will have to choose between organ donation and the right to end their life on their own terms. And they have historically been refused that right to end their life on their own terms, and you're, in essence, kind of continuing that exclusion or burdening of their ability to do so by saying you don't get to donate if you are going this route. So I think there's a lot of problems in that, especially this particular slide, that still have to be worked out. Because after all, none of us really are sure we're ever going to be able to donate. We may well have signed our various registries and things like that. Chances of us ever dying in a manner appropriate to donate are pretty minimal. Why should someone with PAD have certainty about donating? I guess the difference is they know for sure they will never donate. So they know for sure that their expression of their wish is ineffective. Okay, so even if there is a right, even if we get past all this and we say there is a right to be considered for donation, rights are not absolute. There's limits on them. And so where could those limits come from? Well, there's a whole bunch of reasons that we might still say we're not going to accept donations after physician-assisted dying. We could look at potential harms to the donors, of exploitation of vulnerable people, or undue inducement, either to donate and or to have physician-assisted dying, or we could look at harms to others as justifying a blanket exclusion of people who have had PAD from going on to donate. So let me think about what some of them might be. And these apply also in the context of donation in general. And here's where I'm getting back, and this is something I've debated with Megan and Tim a lot, is what to do about the family override or family veto. Whereas outside physician-assisted dying here, but a situation where somebody's registered and donation is sought by the team and the family says, no, you can't do it, against the wishes of the decedent. And we've gone back and forth over this, but it's my view that harm to families has to be an independent consideration at that stage that might justify limiting the, quote, right or extent of our obligation to follow the wishes of the decedent. So anyway, returning to our physician-assisted dying context, another reason not to accept would be medical harm to the recipients. If it turns out that the process of administering PAD harms the organs, obviously doesn't make sense to take them and then harm a recipient. There's the issue of diversion of resources needed elsewhere. What if there's no operating room or personnel available to take someone's donation that they want to make? Well, we would not argue that someone else should be left with nothing in order to divert resources over here to give effect to someone's wish to donate. So there's many reasons why we might not accept a donation. There's also the moral distress of healthcare personnel involved. So if this might be particularly salient in the context of euthanasia, donation euthanasia. And then finally, and importantly in this area too, I think that there's a real reason why we might limit someone's desire to donate if in fact allowing them to proceed would cause serious and foreseeable harm to public support for the whole system, either of organ donation and transplantation or physician-assisted dying, because the cost of giving effect to one person's wishes might be the lives of the many who could be saved if general support for the whole system were maintained. So I think there's many reasons to say that even if there is a right, it's not an absolute right, it can be limited, and those justifications can be limited in a whole range of different ways. So I think that's what I wanted to say, and I think I've went a little too far, but let me stop there and invite your thoughts. Thank you.
Thank you for. There we go. Thank you so much for your fascinating presentation. This is obviously a very topical issue in light of the Carter decision and potential upcoming legislative changes. And as a practical matter, it's something that the medical and legal communities are going to have to confront at some point. So we very much appreciate your thoughts and comments on this issue. We do have some time to open it up to questions and comments. If you would like to ask a question or comment, I would just ask that you use the two microphones that are set up on the sides of the room there.
Hi. I'm assuming that, or I'm expecting that you may have another situation, a person who's needing an organ donation yet is anti-euthanasia and says, no, I don't want, and yet that kind of screening might not be, or labeling, might not be available from a privacy point of view. The second, if I may, just so that I can leave it to you, and would you or somebody else like to comment a little bit more on the impact on the writing of wills and estates?
So I didn't quite catch what you said.
The writing of wills and estates, a little bit more about how this impacts. That's the second question. So.
Okay. Yeah, that's really interesting. I hadn't thought at all of the perspective of the recipients who may not want an organ that has resulted from somebody who has had euthanasia. Yeah, I don't know what to say about that, actually, because I mean, people might have a whole range of reasons why they would not want organs from this type of person or that type of person. We generally don't entertain any of those kinds of objections. So yeah, did you think there ought to be, that information ought to be made available?
Not one way or the other.
Yeah.
I'm just thinking that will probably come
Yeah.
up.
Yeah.
Because the issue is somewhat of a moral, ethical dilemma for some people.
Yeah, yeah. Well, that's very interesting. I don't think I have anything useful to say about that other than I definitely will think about it more. As for wills and estates, that's not my area of expertise, so I'm not quite sure how it would affect. Off the top of my head, unless there's someone here who knows more about that than me, I don't really see what issues would be raised by physician-assisted dying for wills and estates. That you would go ahead and follow your usual process of having a will, I think, and things would unfold as with any other death, I think. Yeah.
My turn?
Your turn, go for it.
You see, I'm from Southeast Asia, and I can tell you there has to be a very strict legislation and a very, very strict implementation. Because we see that the rich guys from the Gulf state, they come there, they pick up the poorest of the poor or the desperate poor people, they buy their kidneys, they buy their organs, and then they die a very miserable death. So if in the absence of any legislation, the misuse of the facilities or the, whatever you want to call it, donation is very much there, and we have to be very careful. I'm not doubting, or I'm not saying that doctors are corrupt or other people are corrupt, but we are human beings at the end of the day, and we can make mistakes. But if there's a law and there's a legislation, the misuse will be minimized as compared to now. And we can see in case of surrogate mothers and all, we are see how it is being abused also. So that is what my comment is.
Yeah, and you're certainly right about the risks of exploitation. Although I would say that I don't think that's unique to physician-assisted dying. I think that that issue you're referring to is an issue with all of live donation. Poor people could be induced to sell a kidney here and elsewhere. But it's much more of a problem in Southeast Asia and other parts of the world, Middle East. Iran is the only country that has a regulated market for kidney sales. I think, in a way, I think the risks of exploitation of the poor are much less in the context of physician-assisted dying because the kind of scrutiny that those cases are going to get in terms of capacity and reasons for requesting physician-assisted dying will be extreme. So I think that that the risk of poor people being shuffled into physician-assisted dying is at least here, is less, I think, than risks for live donation being exploitative here. Yep.
Thank you. I come at this from the perspective of an intensivist who's in the business of the NDDs and the DCDs. And I can tell you that the DCD protocols in Canada are yet evolving. That's not standard of process throughout the country yet. It's my understanding that in both Netherlands and Belgium that both physician-assisted suicide and euthanasia are allowed, and I distinguish deliberately because I believe in Canada we've been asked to define the process of physician-assisted suicide, not euthanasia. And currently the guidelines that are coming down that are being evolved insist that any physician-assisted suicide requires a competent patient, completely competent. If they lose competence, it's off the table. And it also requires that the patient be able to self-administer. And then we stand back and wait. And that process inevitably leads to a long ischemic time, and invariably then organs are not as desirable, which I think, frankly, is a good thing. The process of euthanasia, thankfully, is not on the table, and I don't think anybody in the medical world wants to see that on the table, because that entails what they're doing in Europe, is deliberately injecting, say, a vial of potassium, which we know is going to stop the heart. And of course, then you have a very short ischemic time, and the organs are desirable. And I don't think anybody in the Canadian medical world wants to go that route. And I don't even believe that's on the table right now.
It is actually on the table. The Carter decision, the Supreme Court has not distinguished the two. And most of the interpreters of the Carter decision have suggested the right extends not to physician-assisted dying, but also to voluntary euthanasia.
So the guidelines being evolved, though, by the provincial medical associations and the CMA, though, are not encompassing the world of euthanasia in that regard. The guidelines that are evolving, thankfully, and we should all be thankful for this, quite frankly, because we can all be made donors today. You know, we have that ability. Thankfully, we're not going to be doing that. It requires that we are not going to inject lethal injections. The patient must be able to voluntarily administer said medications and remain competent to the point of the act.
Well, we may be in a situation where the Supreme Court has decriminalized voluntary euthanasia, but the doctors have not chosen to elaborate guidelines for it. Now, the next question is, will you find any doctors who will be willing to administer voluntary euthanasia? It's a separate question, because the court has said no doctors can be required to do it. But they have, it's argued, basically declared that both of those are now decriminalized. So in principle, it is possible.
Yeah. Well, you know, NDD, I think, the neurologic brain death determination of donor status is pretty accepted, but not universally. There's some people who will vehemently argue that. DCD is not unanimously in place in Canada, and that is... the ethics around that get very dicey at times, and one needs to be very careful. We must remember that we are always treating patients first, and these are individuals in front of us with illnesses that we are looking to cure and to return them to a form of quality of life. I don't care if the donor card is signed. My duty is to the patient first, not to the potential organs. And I frankly think we're swinging the pendulum too far in this country. We're almost looking, in the case of patients with signed donor cards, more in the interest of the organs they can give than in the diagnosis and treatment of said individual in front of us. And I think we need to be very careful.
Yeah, I think you're quite right, because DCD only really started in Canada in 2006, and there's all kinds of questions, like how many minutes do you actually wait after circulatory arrest? 5, 10. There was a case in the States of a pediatric heart donation. So donation under the American approach constitutes irreversible cessation of brain or cardiorespiratory function. And there's something a little weird about having a heart attack, declaring someone dead, taking out the heart, restarting it, and putting it. Is that irreversible cessation of the heart function? Well, it is in one person, but not in the other after the transplant. So there's all these funny little issues. And is it irreversible cessation of cardiorespiratory function if you could resuscitate the person, but you're not going to? So there's many of these sort of ethico-legal kinds of questions that surround it. Another one is, can you administer drugs to the person, to, for example, anticoagulant drugs, before the ventilator is removed, in order to make sure that the organs are preserved for donation after the fact, when that anticoagulant is doing no good to the actual patient? So you're doing something to a living person to facilitate a subsequent donation. Now, you can the argument is, well, if the person wanted to donate, it's in their interest, in an extended sense, to have the donation be successful. It's kind of in the cases I'm talking about of an ALS patient or physician-assisted dying, you can have this discussion with the living person. Are you willing to have anticoagulants administered before? It's a little bit easier, I think, almost from the consent standpoint than somebody who's just registered. But to return to your main point, there are issues, other ethical issues beyond these, of course, with all of DCD, not just DCD in this context.
Thank you. I think we have time for one more.
Every recipient of a cadaveric organ has the right to refuse it. So whether it's a pad, organ from a person who is of risk, It doesn't matter. You have your choice. The only time you'll ever get a transplant is when you are in the end stage of life. So it's not common for somebody to refuse, and I doubt they would refuse a PAD organ to save their life.
I think you might be right. I guess it depends how strongly you're against euthanasia. Yeah.
All right, well, thank you all for coming here today. I think the diversity of views in this room really highlights the importance of this issue and the need to have discussions on this topic as law and practice continue to develop. So please join me in thanking Professor Chandler for coming here today.